wait till after the first trimester, which is 13 weeks. So some people may want to visit the clinic earlier once they've not seen their period to confirm pregnancy and ensure that all is well. Now, for patients who conceive through IVF, I think I've explained that antenatal registration is after the luteal support and cervical sacrilege. Who to see during your antenatal clinic? So for us here at the Jude Center for Women's Health, next slide. The antenatal care is provided by a team of doctors and nurses. All right, so it's a teamwork. All right, and this includes obstetricians, neonatologists, anesthesiologists, medical officer, residents, midwives, neonatal nurses, and breastfeeding nurses. So it's a team that takes care of your antenatal. All right. You are seen by the above team at different times during your antenatal care and delivery. Okay. So, first antenatal clinic visit, what we call the booking visit, is the time you come in. That is your very first visit, where you meet with the doctor, you meet with the nurses. The nurses will first of all take your vital signs. So that's number one, vital signs mandatory. All right. Anytime you come to the hospital for your antenatal clinic visit, you must make sure you do your vital signs. Very important, particularly for a woman that is pregnant. We will go on to tell you what those vital signs are and why they are important. And then you have your medical documentation, which is very essential. Like I said before, most of our patients who go through antenatal clinic at our center are women who are coming from the fertility center. So we already have their history. So we don't need to start asking you questions again, but we have all of those ones documented. All right, so all you need to do is to just make your payments, and you have some investigations done. There are some investigations we already have done before that we have. And so you will not need to repeat all of that. So there are lab tests that are required to be done, and then you start your medications. Okay, so talking about the vital sign, because that is the first thing you do when you come to the hospital. Next slide. When you come to the hospital, they are mandatory, not optional. They must be done before you see the doctor or the midwife. And when your vital signs are done, just ask, so how are my vital signs? Okay, they're fine. Oh, this is not okay, but your doctor will explain more to you. When you see your doctor, make sure you ask about your vital signs, particularly if you have been told by the nurse that one of the vital signs was not okay. All right, it's important for your knowledge and information. So what are the vital signs that are checked? Next slide. The vital signs that are checked. Number one is the blood pressure. Blood pressure. Blood pressure, very, very, very important. All right? The blood pressure is very important. So we'll just go through them, and then I'll take them one by one. All right? Blood pressure. Number two is what? Your pulse. Your pulse rate. You want to know what your pulse is. Number three is respiratory rate. Number four is what? Your oxygen saturation. Number five, your temperature. All right? That is not all. Still about your vital signs, we want to know your weight. Yes, your weight, your height, and with your weight and height, we can calculate your BMI, your body mass index. And then, very importantly, we want to check your urine and do urinalysis. All right? Next slide. Okay, so blood pressure. Why is routine blood pressure very important? It is very important because why? Pregnancy can cause hypertension, what we call pregnancy-induced hypertension. What that means that a woman is not hypertensive before, has normal blood pressure, everything is fine, and then because she's pregnant, blood pressure now begins to go up. All right? Blood pressure now begins to go up. It is caused by what? By pregnancies. And pregnancy-induced hypertension is a common cause of maternal mortality and morbidity. There are 5 common causes of maternal morbidity and mortality in our environment. Number 1 is what? Bleeding, what we call obstetric hemorrhage. Number 2 is hypertension, hypertensive disorders in pregnancy. Number 3 is infection. Number 4 is complications of unsafe abortion. And number 5, obstructed labor. Those are the common, the other one, but those are the common causes of why a woman would die while pregnant or 42 hours after delivery. And so you see why we don't joke with blood pressure. Because the reason why women die from blood pressure because blood pressure went up and nobody knew, undetected. And so when you come to the hospital, you must make sure they check your blood pressure and you know what it is. All right? And then you check your blood pressure about 10 to 15 minutes after you have come to the hospital. Next slide. So how is this done? They normally will check your left arm. That is why I think when you enter into that our nursing station, you sit like this, right? And your left arm is put there, correct. Because it's the left arm that is usually checked. So they measure the systolic and diastolic. There are 2 readings when you do your blood pressure. The upper one they call systolic. The lower one is what? Is the diastolic. Now, the upper one should not be more than 140. And the lower one, the diastolic, should not be more than 90. If it's 140/90, that means your blood pressure is high. All right? Next slide. Okay, so same thing said. So anything above 90 for diastolic is high. Now, for systolic, sometimes you may have a systolic of 80/90 and diastolic of 50/60, meaning that the woman who has the blood pressure of 90/50, is it normal or abnormal? It's abnormal, Abi. It's low. But for a pregnant woman, it's normal. So as long as the woman is pregnant, she's fine, she's not feeling dizzy, she's not bleeding, everything is okay, she can have a blood pressure of 90/50. No problem. You understand? Because of the pregnancy hormones that brings about dilatation of the vessels, that causes a reduced resistance to blood flow. And so they can work with that blood pressure and everything will be perfectly normal. Why is a woman who is not pregnant, if she has a blood pressure of 80/50, she will just collapse? That means there's a problem. But for a pregnant woman, that is not an issue. Except, of course, there are challenges. Do you understand? A woman is feeling dizzy. A woman is bleeding. A woman is stooling. A woman who previously had a blood pressure of 120/180 now has a blood pressure of 80/50. That's a problem. But what I'm saying is that for a woman who has a normal low blood pressure and there's no complication, no issue, and she's perfectly fine, that is okay. There's no cause for alarm. All right? And what we normally say is that the diastolic blood rise in pregnancy carries more significance. Meaning that between the systolic and the diastolic, which of them is and are we more afraid of? Is the lower one. A woman who has a systolic of 140, 150, it can be due to stress. You did not sleep last night. Your husband did not give you money. You understand? All of those things can cause your blood pressure to go up. But if And it is the systolic that will go up, the upper one. But when the diastolic begins to go up, then that means there's a challenge. So we are normally more afraid. So when I see a woman who comes and we take the blood pressure and it says 150/80, I'm not worried. So I start asking, did you sleep last night? I say, oh no, I didn't sleep. I was very busy. This. Okay, that's why your systolic is high. You understand? Oh, something happened in my office. Oh, a lot of pressure and all of that. Okay, that is why. So what does blood pressure do? Blood pressure measurement, it measures the blood flow in your body. It also measures how fast your heart is pumping blood. Okay, now, so we are talking about the pulse rate now. We have left blood pressure. We are talking about the pulse rate. It tries to measure blood movement in your body, how fast your heart is pumping blood. Okay? The normal rate for your pulse is 60 to what? 100. And so no, usually if it's the monitor they are using and they put it, it measures everything. It measures blood pressure, at the same time it measures the pulse, at the same time it measures the oxygen saturation. All right? But if they are using their wristwatch, they'll put their hands. This one is manual. They'll put it on the pulse here and measure. Okay? That one is the pulse oximeter. That one measures the oxygen saturation. It can also measure to your pulse. All right, but mainly is the oxygen saturation. So a rate above 100 is high. That means your heart is pumping very fast. And a lot of women, when they are pregnant, their pulse rate goes up. Again, because of the hormones of pregnancy. All right? Because of the hormones of pregnancy, because of the fact that they are pregnant, all right, the heart has to supply blood to both the woman and the fetus. So there's an increased heart rate, also because increase in blood volume, because your body is preparing for that day of delivery where some blood will be lost. So when a woman is pregnant, there's an increase in the total blood volume. And because of this increase in blood volume, it also increases your heart rate. So when we typically see a woman having 100, 105, we don't get worried. Okay? Because we know that in pregnancy, there would be an increase. Okay? So that's what I've tried to do here. But there are other things, next slide, there are other things that can also increase a woman's pulse. One of them common is what? Is anemia. When a woman's blood level is low, your pulse cell volume is low. Fever. When a woman has fever, the body is hot from malaria or whatever, typhoid. If you have fever, your pulse rate will be high. So you can come to the hospital and you can just put your hand and they put that stuff on your hand, the pulse oximeter, and then they tie your hands, and then the nurse say, why is your pulse so high? As she's asking the question, she's answering the question. Because as she's tying it, she's also feeling that your body is hot. And when they check the temperature is high. So that can explain why the pulse is high. Or if your temperature is not high and then your pulse is very high, you should just check your conjunctiva like this and see whether you are pale or not. Oh, you look pale. Then we'll have to send you to the lab to check your blood level. Because those are all the things that can cause your pulse to be high. And of course, just as you have high pulse, you also have low pulse. Anything 60 and below is low. Okay? And what are the conditions that can cause that? Cardiac conditions, drugs, all of that can all reduce the pulse rate. Okay, so the next is what? Your respiratory rate. It measures your rate of breathing. And what is the normal pulse? No, sorry, the normal respiratory rate. The normal respiratory rate is 18 to 22 cycles per minute. But we should note that your respiratory rate in pregnancy increases. So you see a woman breathing fast. I'm sure there's some people, I don't know if it happens to you, where someone will just sit at, you are breathing fast. Your breathing is fast. You yourself may know or you may not know, but somebody who is sitting by your side will just know that, why's your breathing very fast? Particularly if you just walked or you just climbed stairs. You understand? You're trying to catch your breath, so your breathing will be fast. But even if you've not done any of that, your breathing just normally will just be fast. Okay? So increases in pregnancy and after activities. Okay? There are other conditions too that can increase your respiratory rate. If you have respiratory conditions like upper respiratory tract infection, pneumonia, all of those things that affect your respiratory system, they can bring about an increase in your respiratory rate. So typically, what happens that when you come to the clinic to do your vital signs, you don't just walk into the clinic and walk straight into the um, vital signs room. Is that what they do, North Victoria? So you ask them to sit exactly. Because imagine someone just driving to the hospital. Oh, time has gone. You are doing James Bond. You are rushing, and then you get to the hospital, and then you just rush. No, no. If you do that, one, your blood pressure will be high, your pulse will be high, respiratory rate will be high. So they ask you to what? Sit down, relax, calm down. And after 15 minutes or so, then you can now go on to do your vital signs to get the accurate reading. All right? Then next is your oxygen saturation. So this basically just measures your oxygen, the saturation of the amount of oxygen you have in your blood. Okay? To ensure it, because oxygen is carried by the blood and supplied to all the cells. That's essentially what the blood does. Okay? The hemoglobin binds to oxygen. The hemoglobin is contained in the red blood cells, and then that takes it around the body to the different cells. All right? And so when you do your oxygen saturation, what you want to be seeing is 98 to 100. That's perfect, normal. And if your Paxil volume is low, then that volume will also will be low. If you're having respiratory disorder, all right, maybe pneumonia, for example, that also will also cause the oxygen saturation to be reduced. Okay, so lower values below 90 indicate challenge with oxygen getting to the blood. And then the next is temperature. All right, the temperature. Normal body temperature is 37 degrees centigrade, range 6 to 37.5. Temperature of 38 and above is high. And when you have that temperature range, your body will definitely begin to heat up. Okay? So common causes of temperature in our environment, malaria, typhoid, and upper respiratory tract infection. Next, your weight. Very important, because with pregnancy, you are bound to increase in weight. So we want to know what your weight is at the beginning, and as you come for your antenatal clinic visit, we also want to check your weight to see how you are adding weight. Okay? To see how you are adding weight, and to ensure that you don't, we're able to monitor your weight gain. Absolute weight and BMI are checked. And also your weight also can affect your pregnancy. That's how we say obesity can affect pregnancy outcomes. All right, so absolute weight 90 kg and above, not cool. 50 and below is what? It's not cool. So between 50 and 90 is great. All right, what is the estimated weight gain? Next slide. We expect that every week you should gain how many kg? 0.5. That means you are gaining weight. So you come to the clinic today, they measure you, your weight is 72 kg. And they say, come in 2 weeks' time. When you come in 2 weeks' time and they measure you, your weight is now 73. You have gained weight. That is appropriate. So you gain 1 kg, I mean 0.5 times 2 in 2 weeks. 2 weeks you get 1 kg, that is fine. All right? If you don't gain up to 1 kg, it doesn't mean that it's still not fine. All right? But I just say that is the expected gain, the weight gain that we expect. All right? Now, what is the total weight gain we expect during the course of your pregnancy? 15 kg. 15 kg is what we expect. Meaning that if you started your pregnancy and you weighed, for example, 70 kg, by the time you are going to be delivered, when you are getting close to delivery, what should be your weight? At least 85. You started with 70, now 85. It doesn't mean that if you now get to, if your weight is now 80, that means that, hey, there is problem. And my baby did not grow well, there's a challenge. No, 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 no. These are all expectations, all right? It's a range, all right? So, a routine weight estimation is what is important. Another thing that we also do too, next slide, is to determine your height. No, height does not change. So the reason why we determine height is so that we can measure your body mass index, which is a more reflective, a more instructive measure, because absolute weight alone will not cut it. If a woman is tall and her weight gain is to that degree, the only way you can be able to ascertain the impact on her obstetric process is by doing the body mass index. So that is why we measure the weight, the height, because it's important to determine the pelvic capacity and ease of vaginal delivery. Okay? So height and weight often measured together to determine your BMI. So, next slide. So talking about the BMI, you use your weight and the height to determine the BMI. And that is determined by the weight in kg divided by the height square, meter square. That determines your BMI. So what is the normal BMI? 20 to 24. 20 to 24 is the normal BMI. 25 to 29 is what? Is overweight. 30 to 34 is what? Is obese. 35 and above is what? Is morbid obesity. 15 to 19 is what? Underweight. And less than 15 is extreme underweight. The question is that, what is your BMI? Where are you? Are you in the normal? You don't know. North Victoria. How come you've not determined the BMI of this my patient? Huh? You do it. And so they should know now. They should know which category they fall in, whether they are normal, overweight, obese, but just using my eye to check out all of you now, right now, yeah. I don't think any of you is obese. I'm not overweight. Yes, one or two of you may be, but obese, no. All right. So it's important for us to check our weight and so that we can calculate weight and height, so that we can calculate our BMI. Okay. It's important because when you see a woman whose BMI is very high, who is in the range of obesity or morbid obesity, they have challenges with pregnancy. Therefore, they have challenge with even getting pregnant. And when they get pregnant, they have challenge with the pregnancy and all of those things. All right. Then the next is urinalysis. That is the checking of your urine. That's why every woman coming to the hospital, particularly if you are pregnant, you must check your urine. You must check your urine. There are so many things that you check when you just do that simple test. From sugar to exclude gestational diabetes, which is diabetes occurring in pregnancy, to protein to exclude preeclampsia, renal disease, UTI in pregnancy, to checking your ketones to exclude hunger, starvation, and hyperemesis gravidarum, meaning that excessive vomiting. All right. Next slide. So you continue your urinalysis also. You check your nitrites that will exclude urinary tract infection, urobilinogen that will exclude hemolysis of red blood cells, and then leukocytes that will exclude infection. And then, of course, check your pH. All right? So these are all the tests that are done, and it's important for you to make sure that you do this test each time you come to the hospital. See, I say for a pregnant woman, even if you came yesterday and you came today and say, oh, I want to just beat MD and just say hi, I say, go and do your test, or go and do your vital signs first. All right? It's very, very important. So the first booking visit I said is what? Next slide is your first clinic visit whilst you're pregnant to register at the Center for Women's Health for us to take over your antenatal care. And that will include a detailed medical documentation, your bowel data, obstetric history. When we say obstetric history, we mean your delivery history. For those who have delivered before, how many times have you delivered before? How did you deliver? Was it vaginal? Was it cesarean section? All of those things are all very important. When you deliver, was there any complication? Did you lose blood? Did you develop hypertension? Did you develop diabetes? So many things we ask when we are taking your obstetric history. And your gynae history also very important. We want to find out what's your menstrual cycle like. All right, is it regular? Is it not regular? Did you have any history of infertility? How did you get pregnant? All of those things are all that the gynae history. And then you have your medical history. Are you hypertensive? Are you diabetic? Do you have thyroid disease? Are you sickle cell? All of those things are all very important. Your surgical history, next slide, is important. Have you had any surgery before? Have you had a myomectomy? See, all of these things are all very important because if we don't have this history, we will not be able to manage you. Imagine a woman who has had 2 myomectomies, and then you don't know, and then you now tell her that she's going to deliver by herself. That is time bomb, catastrophe that will happen. Because what will happen that when that woman goes into labor, she has a very high chance of her uterus rupturing. And once that happens, baby will die, even herself too, a very high chance that she will not make it. So that is the reason why all of these histories are very important. The woman who is a known hypertensive, is a woman who you know that, this woman has hypertension normally. Now that she's pregnant, hypertension can worsen the pregnancy can worsen the hypertension. So that woman is already on medication. So you keep checking the blood pressure regularly. That is not the woman that you give 3 to 4 weeks. You say, see me every 2 weeks or every week. Because you want to be monitoring all the blood pressure. See, for most of our patients here, we treat you as high risk. We treat you as top VIP. Why? Because of the way you got pregnant. So all women who go through antenatal here with us, most of them, because of how they got pregnant, we give you very intense antenatal monitoring. Ordinarily, a woman who got pregnant naturally without any complication, we see you every 4 weeks. You get to 28 weeks every 2 weeks. But for you, I'm sure we see you every 2 weeks, right? Exactly. That's because we want to just ensure that we are managing you more intensely. Then your family and social history, very important. All right. And then you do a detailed physical examination. All right. Just to see, to do a physical examination. And then you have a scan done, an ultrasound scan will be done to determine how your pregnancy is doing, confirm clinical pregnancy, determine the number of babies you are having, and the location of the pregnancy. All of that are all done in the first antenatal clinic visit. But for those who got pregnant through IVF, your first scan, which you want to take as your first, although we tell you, because you do what we call a luteal support, so you only register for antenatal after your luteal support. But you'd have done that first initial pregnancy care during your luteal support. Okay? So when you do your scan, you are doing it at the 6th week of pregnancy, 6 weeks plus, 2 weeks after you're tested positive. And that scan is trying to determine, confirm viability of pregnancy, determine the number of pregnancies, the number of babies that you have, and the location of the pregnancy. And then you do your blood test. All right, there are blood tests that are required for you to do for a woman who is pregnant and is registering for antenatal. You'll do your full blood count, your blood group, genotype, and serology test. For women who have a high risk of diabetes, you do your fasting blood sugar or your OGTT. Okay? And then you're giving your medications. All right, and then you're asked to have your next booking. For women who get pregnant through IVF, your medications are slightly bit different because in the initial phase of that pregnancy, you would have been on luteal support. You're taking progesterone, you're taking estrogen, folic acid, and all the other things, aspirin. All right. And once you are done with your luteal support, then you now go on to now start taking your routine antenatal medications. But even at that, for a year, we also add some other medications for you because of how you got pregnant, and just to ensure that, and because you have a cervical sacrilege, we also add a medication that helps to calm your uterus and prevent it from contracting. Okay, and then you book your next antenatal visit. Always make sure you book. Like we said before, every clinic visit is a booked clinic. It's a booked visit. You don't just walk and say, "Oh, I've come for my visit today." How? Do you have an appointment? For that is the first question that funders will ask you. "Ma'am, do you have an appointment?" You'll say, "No." "Why did you book an appointment?" "No, I just came for checkup. My normal antenatal clinic." "Oh, sorry, you have to have an appointment. Your doctor needs to know that you are coming so that we'll prepare for you." Okay? So please make sure you book your next visit. Next slide. Then for the antenatal blood test that we do, I said I've mentioned it, full blood count, blood group, genotype, serology. The serology tests are hepatitis B and C, syphilis, and HIV. Now all of these all have significance depending on how they come out, particularly for the serology. If a woman has hepatitis B, we need to know so that we know how to manage when she's giving birth, particularly as regards the baby. Same also for hepatitis C, of course, for HIV and syphilis. Okay? Of course, your full blood count, we need to know what your blood level is, if there's any infection, and then what your platelet count is. Then, these are the other tests that are done during the course of the pregnancy. Number one is the Coombs test. The Coombs test is usually done for women who are rhesus negative. You know, your blood group type have positive and negative. So you have blood group O, A, B, and AB, right? O is either O positive or O negative. A is either A negative or A positive. So there's either positive or negative. So that's the rhesus factor. Now, for a woman who is rhesus negative, we need to do what we call a Combs test to be able to determine whether you have been sensitized or not. And usually women can be sensitized and they will not know, particularly if they got pregnant before and they did not take an injection to prevent sensitization. Either, irrespective of how the pregnancy ended, if you delivered, if you had a miscarriage, or whatever the outcome was, if you didn't take that injection, you can be sensitized. Sensitization means your body will not develop antibodies that in your next pregnancy, if antibodies have been generated, those antibodies can cross your placenta and go and start breaking down the red blood, the cells of the baby. And so what will happen is that you see a woman who is pregnant and at 28 weeks, 26 weeks, 30 weeks, people just die in her womb. Why? Because the woman's body have generated antibodies that is fighting the blood cell of the baby. And so that is why the blood group of a woman is important. More important is the rhesus factor of that woman. And once the blood she is rhesus negative, this test must be done to determine whether she has been sensitized or not. If she has not been sensitized, then when she delivers, within 72 hours but before she even delivers, during the antenatal, she will take that injection at least once or twice, just to make sure that she doesn't get sensitized. And once she has delivered, she must take that injection within 72 hours to prevent sensitization. Okay? And what is that injection called? It's called ROGAM, anti-D immunoglobulin. And so, fasting blood sugar and 2 hours. Okay, just note your question. Okay, just note your question. You have the fasting blood sugar and 2 hours. This test is done for women who are at risk of developing diabetes. All right? So we will check your fasting blood sugar. If you are doing your urinalysis test and we discover that there's sugar in your urine, we will ask you to go and do this test, your fasting blood sugar and 2 hours. That is after you take your blood before you eat in the morning, having fasted for 8 to 12 hours the previous day. After you've had your breakfast, bless you, 2 hours after, they'll take your blood again to check for your blood sugar. All right? Once it's normal, then that is good. If it's high and it's in the diabetic range, then they will need to now counsel you on your diet, and then you need to start taking medications, injections to control the blood sugar. And then, of course, we do the Group B streptococcus test. This is usually done around the 35 weeks of pregnancy, just to see if this infection is there. Because if it's an infection that is there, then it needs to be treated before delivery. Because if you don't treat it and it's passed on to the baby, it can also affect the baby. It's a bacterial infection. All right? Sometimes common. Okay? Then during pregnancy, there are some blood tests that are done during the antenatal period. Next slide, you have at 28 weeks, you do your Paxil volume and the fasting on 2 hours. That is done. You know why? Because at the initial stage, you may not have, your blood sugar may be normal. But as pregnancy advances, because of the hormones of pregnancy, it may begin to affect your body such that your blood sugar begins to rise. So at 28 weeks, we just want to check and be sure your blood sugar level is fine. And again, at 32 weeks, we will check your PCV, and at 36 weeks. And then next, obstetric scan. First scan is done during the booking clinic. Okay? I said it's done to determine the location, the number, the viability, and the age of the pregnancy. And then you do routine scan during each antenatal clinic visit. It's not what obtains everywhere. If you don't do scan, the most critical scan you need to do is scan in each of the trimesters. first, second, and third. You do your anomaly scan at the end of the the beginning of the second trimester. But see, the reason why we do scan here is because we have the machine. So when you come for your clinic visit, you want to hear your baby's heartbeat, Abby. Uh-huh. If you just come and they just check and say, okay, just touch and use that thing they used to press and say, I can hear the heartbeat, and they say go, everything is fine. Will you be satisfied? No. But when you come and they put the probe and you hear tick 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 tick, you say yes. I know some patients, if they can have that thing in their house, they'll be checking their babies every day. In fact, some will do it 3 times a day to be sure that everything is fine. All right, so we do that here each time you come for your clinic visit, and then you do an anomaly scan. That we don't usually do here, okay, just to be truthful. And then you do your, we have a 4D scan, all right? That scan in my office, that's a 4D capacity. Just that we are not yet providing that service because that service will be an additional cost. And this is my patient, the way I'm looking at their face, money, money, money. They're not ready to spend that malaka well. But very soon this year, we're going to start doing that so that you can see your baby in a fourth dimension, like a picture of how your baby looks inside your womb. Say that would be nice, Abby. Exactly. So, but just be prepared to pay the things that accompany it. All right. So next slide. So what are the schedules of antenatal clinic visits? So like I said before, for normal low risk pregnancy, the client visit as follows. Your booking visit to 28 weeks, you do 3 to 4 weeks. All right. All right. Also, just 2 more slides and we'll end for this session. We'll continue next time because I know that a lot of information is being passed on. All right. 3 to 4 weeks, and then from 28 weeks to 36 weeks, we do 2 weeks. From 36 weeks, we do what? To deliver, we do weekly. Now, more frequent visits when the need what arises. Like I said here, because we treat you, all of you that got pregnant through via IVF as special high-risk patient, we see you more frequently. So we do 2 weeks. And if possible, we do weekly. Okay? So what do we do? So I think I will just take this 2 and then I will stop. What must be done at each ANC visit? So the first is that you must do your vital signs and confirm results. All right? And then you interact with your doctor or midwife. You know, when you come and you sit down, the doctor will ask you, how are you doing, madam so and so? How's it been? Fine. Any complaints, any fresh complaints? Say, doctor, no, just that. You know, sometimes I find it difficult to sleep. Doctor will say, well, that is normal. All right. Anything else? No, everything is fine. Okay, that's good. Then you say, okay, climb so that we can scan you. So you must always have an interaction with your doctors and midwife. And that interaction starts from when you are doing your vital signs. So how am I doing? So you don't talk when they are measuring it. You put your hand after you are done. So how was it? Oh, everything is fine. Everything is perfect. That reassures you. Okay? Most times when everything is fine, doctor will not say anything. So you can ask the doctor just to be sure. Doctor, how are my vital signs? Oh, vital signs are wonderful. All right? And then you check yourself and check the baby. How do we check the baby? By scan. We'll measure the baby's heart, measure the baby's parts to be sure that baby is growing well. And what do we do to determine that? We measure the head, we measure the femur. All right? If we got 28 weeks, you are 28 weeks today. In 2 weeks' time, when we measure, we should be getting what? 30. That means you have grown. So that's how we use to measure that baby is growing. Okay? And then if you have a lab test to do, you go to the lab, have the test done, If not, you pick up your routine medications if you are done with the ones you were giving, and then you schedule your next visit. So that's basically what happens during your antenatal clinic visit. So that is the routine. So you must know that that's the way it goes. No one, you don't skip anyone. Okay, that number one, you don't skip it. So don't go and pee before you come to the clinic and say, sorry, I don't have urine. I just peed before I came. You must pee. They will tell you, go and take water. Don't worry, go and see doctor. As you are coming back, branch, that pee, you must pee. Because we want to check and see that all is well. All right? And then lastly for today, what are your routine medications? So you have your hematinics, pregnant care, ferritin. It all depends on what is being given to you. Now I think we are giving safe preg, right? Yeah, safe preg. All right. Essentially, what you need is just iron, folic acid. Those are the two most important elements. All the other ones, eh? Calcium, vitamin C, the B complexes, vitamin D, all those are all Jara, omega, the most important, folic acid and iron. And so you're giving hematinics, you're also giving anti-malaria. Anti-malaria prevention, why? Because we live in a malaria endemic environment. And so because when a woman is pregnant, your immunity is low, the normal malaria that you will have when you are not pregnant that will not do you anything. When you get pregnant and you have malaria, it will become an issue. And because of the complications that can result, that is why we give these medications, Paludrin and Fancida. They are anti-malaria prevention. They prevent you from having malaria, or if you are going to have it, it reduces the severity and reduces the frequency. Do not say, oh, doctor, I thought I'm not supposed to have malaria. I've been taking Paludrin faithfully. I've been taking Fancida. How come I still have it? Yes, you can still have it, but it will not have been severe if you were not taking it. All right? And then Vasoprene, every one of you here most likely are all on Vasoprene, apart from those who have peptic ulcer, who have heartburns. Okay? And what does Vasoprene do? It's a medication we give that it helps to thin the blood, helps perfusion, the blood flow. Okay? So we give that. We give salbutamol because of patients who have had cervical circlage, who are carrying multiple pregnancies to keep the womb calm. And then we give Clovina. Clovina is both an antibacterial and antifungal pastry that you insert. The reason why we do that while a woman is pregnant is to reduce the risk of infection. But women, when you have infection, it predisposes you to having premature rupture of your membrane. And if that occurs before the time is due, then that increases the risk of losing your baby. Because if baby is born before time, that baby will not survive. And we have noticed here that women who are on this Clovina, the risk of having rupture of their membrane is very, very low. So initially, you may be taking it twice weekly. That's the routine. And then after some time, you start taking it every week until you get to about 28 weeks, 29, 30 weeks, and then you stop. And then tetanus injection, you have to take 2 doses in each pregnancy. After the 16th week, and then after 4 to 6 weeks, you take the second one, and then you are done. All right? Thank you very much. We'll stop here. Any question? Okay, there's one of my. Okay, so let's take the question from those in-house here first. There are online people, my people online, they have posted in questions. Okay, so go ahead, madam. Yes.
Because I have one of my friends, he has 8 miscarriages in more. Takes him to get to 3 months they did, is there any other drug that can help why she's pregnant?
So the first thing to do is to find out, to answer your question generally, if a woman is Restos negative, huh, and she has gotten pregnant and delivered, and she didn't take that injection, and she's now pregnant now, what to do is for her to do that Coombs test to find out if she has been sensitized or not. If she has not been sensitized, then she can take that injection in that pregnancy to prevent sensitization. But if she has been sensitized, there's nothing you can do. There's nothing you can do. So what you do is to now try and monitor the pregnancy very closely. Okay? Monitor the pregnancy very closely and see if there's any impact on, on the child. In very advanced societies where they can do surgery in utero, there are some things that can be done if that pregnancy is being impacted. What to do in this environment is that you monitor that child very closely, and once that child gets to age of viability, above 28 weeks, when you can safely deliver that child and the child will survive, you deliver that child and take that child away from that environment, and then you manage it. You care for the child in the neonatal intensive care unit. Mhm.
So, because when I did
Mm.
my segment and before, people worry.
So usually when you see, like I said, normally the way antenatal care is given, you don't do scan regularly. You understand? At that time you did that scan, you're not supposed to even do scan at all. So when you do scan and you measure heartbeat at that very early age, think you're about, not sure how many weeks you were now. The first scan, 8 weeks, 6 weeks, the heart rate will be very high. It's normal. As the pregnancy advances, when you begin to actually look at heartbeat as a factor to see how baby is doing, it's when you are above 7 months. Yes. Anything less than that, the heart rate can be very. That's why, they'll tell you that, see, don't worry, everything will be fine. Because you expect the heart rate to be very high at that age of pregnancy. All right? Okay. Any question? Yes, please. What are you not adding? You're not adding weight. How are you sure?
I'm sure that because
Because anytime you check your weight.
not supposed to say I'm weight I am. But when you now say they're supposed to have at least
So in the last 4 weeks, have you added weight at all?
not really. Because it's just between sometimes it's 79 points.
Mm-hmm.
So now go to 78. I come to 78. So it does that not agreeing to go to 80.
It's not agreeing to go to 80. Okay, the weight is not agreeing to go to 80. And you want the weight to go to 80.
No, when the nurses said I'm okay.
Yes.
But when you are now saying it's and they said the baby is big. So that means it's me that is big.
Yes, so now. So how's your eating? Are you eating well?
I'm eating, but not like pregnant women that
How do pregnant women eat?
you crave
You crave for
for things.
things. Yeah, you don't have. Yes.
I don't have that excess craving.
Yes.
I just eat small at a time. I'm okay. So I
Good.
don't eat. I don't eat that kind in between. I don't eat like that.
It's fine.
But during the first trimester, the
Mm.
6 second trimester,
Mhm.
stop.
Mm. not. It's okay. It's fine. So, like I said before, I said this is what is expected. But however, if you're not meeting that milestone, there's no problem. What is important is how is the baby doing? Is the baby growing? If baby is growing, you know, that's what is important. As long as the baby is growing and you two you're also fine, no, no wahala. Hmm? You are good. All right. Any question? Okay, so there's a question here from our online audience. He said, I have not been told my BMI. Okay, so when you get to the hospital the next time, ask the nurses to tell you your BMI, your body mass index. They will calculate it for you. Like we said before, it's your weight over your height square. They will calculate it for you. And based on what we have presented, you'll be able to tell where you fall in, whether you are underweight, normal, overweight, obese. There's no morbid obese in this in my clinic. No pain. None of my patients is morbid. So I wouldn't even mention that at all. All right. Okay. Any further question? You're always afraid. Tell that fear to go back. See. So why can't you sit down for long? Do you feel pain? Do you feel pain when you sit down for long? Mm. Well, when you are pregnant, it also depends on the number you're carrying. You know, you cannot really sit for long. In fact, I don't even encourage anybody to sit for long. See, you see the way people are sitting down. When you're sitting down, like your leg must be moving. Because sitting down for too long can make the blood to just remain in one place, and that is not good for a pregnant woman. In the same vein, when you sit, don't cross your leg like this. A pregnant woman cannot sit and now do leg as if you are doing guy. You have to do like this, and then you make sure that the shoe you are wearing too is not too. There's no high heel. Let me check. Okay, wait. Just small. Perfect. 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 It's okay. One of you are fine. Even it's just a little bit. So no high heel. High heel is banned. All right. So that guy, you after you have delivered, you can now begin to do your guy. So for now, just go on flat. Okay. And then please make sure you're taking a lot of water. So I'm glad that I'm seeing people with bottles of water. It's very good. Okay, there's one there. Who has that one? For you? Where's your own? Aha, correct. Everybody, make sure you have your bottle of water to take, and make sure you're eating healthily. Like what you said, yes, you cannot eat so much at a time, but you can eat intermittently. But if based on your schedule it doesn't work, no problem. But just make sure that you are eating. You know, sometimes people say I eat only when I'm hungry. When you are pregnant, you don't only eat when you are hungry. You eat because you know you have to eat for the baby. Yes, you feel full, you stop after like 2-3 hours again, and you can just to take a snack, just something small, all right, but intermittently like that, and then you'll be fine. Okay. So, do I have any more questions from our online audience? I do. No. Okay. So, I want to, on behalf of the team, say a big thank you to every one of you, both those of you who are physically on ground, and for all our online audience, our clients who join online. I want to say that I wish you a very uneventful antenatal period. Just like we have it in the university. All of you are in different classes. There are some of you that are quarter to graduate. Some of you are just started. You are in 100 levels. Some of you are in the middle. But wherever level you are, just know that very soon, not long from now, you will get to the finals and then you will graduate well. And then you will have your babies. All right, so I want to say that please, for those of you who are having your antenatal here with us, if there's any challenge, just call the front desk. If you call the front desk, you're not reaching them, just come to the hospital. Do you understand? Don't say, oh, can I come now? No. Once you think you are not feeling okay and you need to see a doctor, just call them and then you start coming. All right? We are here to serve you, to provide care. If at any point we think you think you're not getting the service that we promised, please reach out to us. Reach out to me. Okay? And under God, we will try our best to ensure that we provide you, we serve you, and by the grace of God, we shall all have a successful delivery. I look forward to taking you through your delivery. For those of you who will deliver in this hospital, for those of you who will deliver in America, okay, America, people are not going to America anymore. Donald Trump has said no more passports again for. Okay, I'm not getting it. There's a question. No, I'm not getting it. All right, so for those of you who are going to deliver in other facilities, particularly for my online audience who are not based in Abuja, please make sure you go to a facility that is equipped. You can't play Rolex with your life. Don't say, oh, because of money. Yes, there are centers that are good, but not so expensive, particularly if it's a government center. But even some government centers, make sure you go to a center that is equipped. Don't go and deliver in a primary healthcare center. Okay. What should one do to stop repeat? To stop repeat, if informed that protein was found in urine, and what is the likely cause? Okay, what do you do to stop protein from? Okay, so like I said, if you do your urinalysis and there's protein in your urine, it could mean several things. It could mean that it could be due to contamination. That's one. And so you need to repeat it again. Or it could mean that there is what we call preeclampsia, that is high blood pressure with proteinuria, protein in the urine. So when you check your blood pressure and your blood pressure is normal, then it's not likely it's preeclampsia. It could be due to infection, UTI. All right, so if that is present, then you may need to now do a culture of your urine to see if there's any urinary tract infection. All right, so those are the possibilities. But normally, what will happen if it's just 1+, in which case it's not so significant and you don't have any symptoms of UTI, your blood pressure is normal. What we do, we tell you take a lot of water, and then when you come in your next visit, we'll repeat it, and oftentimes it's clear. Okay, so that is what we do. All right, so thank you very much. Thanks for coming. We appreciate you. And then please make sure you continue to attend your antenatal clinics. All right. And then, like I said, ask questions from your doctors who attend to you and get involved in your care. And I wish every one of you, and those of you who are watching online who will not deliver in our center, I wish you a safe delivery. And please, particularly for our clients who went through our IVF program, when you deliver and it's not here, send me my baby's pictures. I beg you. Thank you. Have a nice weekend.
Yes, sir.
I'm in my second trimester. Trimester though. Then after your cyclage, is it advisable to sleep with your husband?
we tell the husband, just stay on your lane, don't come close. Because we don't want anything that would. The first thing I want to say is that if you don't have any symptoms, don't worry. It doesn't mean you are not pregnant. I say, doctor, I'm not even feeling pregnant at all. Are you sure I'm pregnant? Relax, be calming down. The fact that you don't have any symptoms does not mean you are not pregnant, because some patients will not have any pregnancy symptoms at all. Why some patients will have some pregnancies? But some patients have pregnancy, they don't even know they have it. When you now start asking them, okay, do you feel weak? Okay, do you sleep more? Oh yes. Your boobs, are they bigger? Tinkling sensation? Oh yes. These are all part of the. Are you eating more? In fact, I'm craving some things that I don't used to crave before. All of those things are all part of early pregnancy symptoms. It's just that it varies from one woman to another. What may be your pregnancy symptoms may depend on what your pregnancy